Okay, looking at the muscles that act on the glenohumeral joint now. We can functionally divide these muscles into the superficial anterior muscles such as pectoralis major, the superficial posterior muscles, lat dorsi and teres major, the lateral muscles, deltoid, and then the deep stabilizing muscles, which include the rotator cuff muscles, the four muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. Starting with pectoralis major. Here we've got pectoralis major. We see it. All of this is pectoralis major. It's a huge muscle, very large, powerful muscle that covers the anterior chest wall. Anatomically, we divide pectoralis major into two heads. This head here, which comes from the clavicle, from the medial third or medial half of the clavicle on its anterior border, that comes obliquely downwards and laterally and wraps around the humerus. That's the clavicular head, and over here we have the sternal head, which arises from the body of the sternum, the costal cartilages of the upper 6 or 7 ribs, and the aponeurosis of the external abdominal oblique. Again, this passes across, and this passes behind the clavicular head, where the two heads blend together, two lamina blend together. They form a flat tendon which attaches to the lateral lip of the intertubercular sulcus on the humerus. Its function is to produce adduction of the glenohumeral joint. It also produces medial rotation of the glenohumeral joint because it wraps around the humerus. The clavicular head is a flexor of the glenohumeral joint of the shoulder, and the sternal head has got the ability to extend from a flexed position. This is a very powerful muscle that is exercised when we do activities such as bench press and press-ups. The nerve supply to pectoralis major is via the medial and lateral pectoral nerves, C5, 6, 7, 8 and T1. Posteriorly, we have latissimus dorsi. Now, latissimus dorsi is a particularly interesting muscle because it's the only muscle that unites the pelvic girdle to the pectoral girdle. It's a large, powerful muscle that attaches from the spinous processes of T6. We've got T6 here, all the way down to T12. It then attaches to the thoracolumbar fascia, this white structure that we can see here, blending over here with the spinous processes of L1, 2, 3, 4, 5, right down onto the sacrum. This is a thoracolumbar fascia down here. It also attaches to the posterior lip of the posterior half or posterior third of the iliac crest. Fibers pass upwards, and as they go up, they twist on themselves before attaching finally into the floor of the intertubercular sulcus, so right in the center of the intertubercular sulcus. As it passes upwards, it may also give an attachment. A few fibers may go off and blend to the lower 3 or 4 ribs, and occasionally to the inferior angle of the scapula. The action of latissimus dorsi is to produce extension. It's a powerful extensor of the glenohumeral joint, adduction and medial rotation of the shoulder. Its action is that of putting your hand into your back pocket. It's often called the climbing muscle because whenever we lift an arm up to grip a ledge and pull ourselves up using this muscle, it's the main muscle of action. In this situation, the distal attachment, the humeral attachment, becomes the fixed point, and as we pull on the muscle, it lifts the pelvic girdle up towards the pectoral girdle. The nerve supply to this muscle is via the thoracodorsal nerve, C5, 6, 7 and 8. Teres major also sits on the posterior aspect of the glenohumeral joint. It's a short, chunky, round muscle. Here we've got teres major here. Up here we've got that supraspinatus at the top, infraspinatus and teres minor, and then this little muscle at the bottom that arises from the posterior aspect of the inferior angle of the scapula and the lower part of the lateral board of the scapula is teres major. It's a short, strong, round muscle. It comes across through the axilla to pass anteriorly with latissimus dorsi. Latissimus dorsi is coming up here to attach onto the floor of the intertubercular sulcus. Teres major attaches to the medial lip of the intertubercular sulcus. So on the intertubercular sulcus, we have pectoralis major lying on the lateral lip, latissimus dorsi lying on the floor, and then teres major lying on the medial lip. The actions of teres major are similar to latissimus dorsi. It is an extensor, adductor and medial rotator of the glenohumeral joint, and its nerve supply is via the lower subscapular nerve C6 and C7. So they're the muscles that form the anterior and posterior aspect of the glenohumeral joint, the superficial muscles. Laterally, we've got a huge muscle called deltoid, very strong muscle, anatomically divided up into three sections. The anterior fibers arising from the anterior border of the lateral 1/3 of the clavicle, the middle fibers passing from the lateral border of the acromion process, and the posterior fibers passing from the inferior border of the spine of the scapula and the fascia that covers infraspinatus. So it's got this very large linear attachment going from clavicle, acromion process to spine of the scapula. It mirrors, it's almost the continuation of the distal attachment of trapezius, where trapezius comes down, attaches the posterior border of the lateral third of the clavicle, medial border of the acromion process, and then superior lip of the spine of the scapula. Deltoid looks like its continuation. The anterior fibers and the posterior fibers form typical triangular muscles that converge into a common distal tendon, but the middle fibers are your classic multipennate structure. The actions of these three muscles are the anterior fibers will produce flexion of the glenohumeral joint and medial rotation. The posterior muscle will produce extension and lateral rotation, and the middle muscle, the middle fibers, is a strong, powerful abductor, abductor of the glenohumeral joint. As they converge distally to attach onto their final attachment, they insert into a structure called the deltoid tuberosity and via a short, thick, strong tendon. This can clearly be palpated, and deltoid is what gives the shoulder its contour, its classic rounded shape. The nerve supply to deltoid is via the axillary nerve, C5 and C6. Now, the axillary nerve can get ruptured or can get torn in dislocations of the glenohumeral joint. And as a result of it getting torn, we can end up seeing a loss of function of the deltoid itself. The rotator cuff muscles are four muscles that attach onto the top of the humerus. These are often called musculotendinous muscles. The rotator cuff are a group of four muscles that act as a muscular tendinous ligamentous structure. They act like fingers that pass from the scapula to the top of the humerus, drawing the head of the humerus into the glenoid fossa. These are the primary stabilizers of the glenohumeral joint, not just because they're muscles that are crossing the glenohumeral joint, but also because the tendons of the rotator cuff blend with the capsule, further reinforcing it. The most superior of the rotator cuff muscles is this structure here. It's supraspinatus. It sits above the spine of the scapula, hence its name, arising from the medial 2/3 of the supraspinous fossa. It passes laterally under the coracoacromial arch here before inserting onto the top of the greater tubercle. Its course here under the coracoacromial arch, we can see there's the coracoid process, there's the coracoacromial ligament, and there's the acromion process. Here is supraspinatus passing out laterally, and as it passes under the coracoacromial arch above the humerus, it is prone to impingement, and supraspinatus tendinopathy is not at all uncommon. Its action is as an abductor of the glenohumeral joint, and it's believed to be the initiator of abduction. It produces the first 15 degrees of abduction, primarily because deltoid is in a bad line. Its alignment, the alignment of deltoid is such that if it was to contract on the dependent arm, it would just draw the head of the humerus upwards. The nerve supply of supraspinatus is the suprascapular nerve from the anterior prime rami of C4, 5 and 6. Important little muscle. As I said, it's prone to impingement and it's also prone to degeneration. Infraspinatus arises from the infraspinous fossa, the medial 2/3 of the infraspinous fossa. This is infraspinatus here. And this is the spine of the scapula again. This is the infraspinous fossa. Infraspinatus passes laterally. We can see it coming up here and blending onto the middle facet of the greater tubercle. There's supraspinatus attaching onto the superior facet, then infraspinatus, and underneath this we've got teres minor. Again, the posterior part or the upper part of infraspinatus passes under cover of the posterior acromial angle. The actions of infraspinatus are to produce lateral rotation of the glenohumeral joint, and again its nerve supply is the suprascapular nerve, C4, 5 and 6. It provides posterior stability to the glenohumeral joint. Again, it's an important posterior stabilizer. This is teres minor down here, arising from the upper 2/3 of the lateral border of the scapula. So there's infraspinatus, quite a large muscle. This is teres minor that comes up and meets it. So here's the distal attachment. There's infraspinatus passing onto the middle facet of the greater tubercle, and this is teres minor inserting onto the inferior facet or lower facet of the greater tubercle. Again, the actions of teres minor are to produce lateral rotation, and it will assist with adduction. Nerve supply of teres minor is the axillary nerve C5 and 6. Again, occasionally taking a small branch from C4 as well. Anteriorly, we have subscapularis. Subscapularis is the major stabilizer of the anterior glenohumeral joint. It lies between the scapula and the posterior thoracic cage and arises this time from the medial 2/3 of the subscapular fossa. Here we can see subscapularis here. This is the thorax has been removed, and so we can see subscapularis here lying on the anterior surface of the scapula itself. It passes anteriorly here, being separated from the glenohumeral joint by the subscapular bursa before inserting into the lesser tubercle. Here we can see the lesser tubercle over here. Its action is medial rotation and adduction of the glenohumeral joint, and its nerve supply is via the subscapular nerve C5, 6 and C7. Subscapularis is an important anterior stabilizer.